Greetings to everybody. Today we are going to have our 37th intergenerational meeting. We have a very important and who is going to enlighten us, a guest, Professor Dr. Norman Sartorius. I will say only one thing about him. He is a living legend of psychiatry. We have our guests to have a discussion with him, ask questions, and have a fruitful meeting. Welcome among us, Dr. Sartorius. Thank you very much for accepting to be with us. Last time, unfortunately, due to a mistake I have made, we couldn't succeed having our session together. But today, we are very happy to see you among us. We have lots of young students among us. I want to, first of all, would you like to say anything before the questions start?
I just want to see the faces of the colleagues who are with us rather than only their names. So when they are ready to be shown, I'll be delighted to see their face.
Thank you. Thank you. We are very delighted to see your face, and I'm sure they will let them see us, their faces. And well, who wants to ask the first question to Dr. Sartorius? The floor is open.
I can ask a question if I may.
Sure.
Good morning again, Professor Sartorius. It's great to see you as always. Um, my question would be about, would you like to share some insights about the rapid advance of technology and its use in psychiatry, and also artificial intelligence in terms of its psychiatric effects on people globally? Do you have any insights that you want to share, or do you have any recommendations to psychiatrists who will be for sure encountering the effects on these? What should we follow up? Did I make myself clear? I can.
Özge, could you please say a few words about yourself?
Yes. I consider myself as a very early student of Norman Sartorius. It was when I was when I was a psychiatric trainee. We met in Heybeliada in Istanbul, Turkey. And after that, after finishing residency, I have worked in several university hospitals, and now I am an associate professor of psychiatry. I teach neuroscience in Institute of Health Sciences in Bezmialem Vakıf University. Also, I see patients, and I am a new mother of 4 months old boy. I already shared this with Norman Sartorius. It's kind of intersection time for me. I'm slowly starting to work, and the reason
No,
why I'm asking this is the thing. There are two things. One is a lot of information is being gathered from us through technology, and this will be stored And oh, I know it's a big question. And the other thing is,
It was just a small information which I asked. Let's give some time for
sure,
other.
sure.
Please. Thank you. Thank you for asking, for introducing yourself and asking your question.
Well, I think it's a central question to much of what we are doing today. It's the simple way answer would be that the technology which we have is a splendid servant, but a very poor master. And we have allowed it to become a master where it should have been no more than a servant. We are now seeing the consequence of this, particularly among younger people, children who are not learning how to be with other people. They're learning how to be with their technological tools. They are splendid in using the telephone, but they do not know how to behave with people whom they have never seen before. When should they smile and when should they not smile? What, how do they open themselves? And I think that there are various areas in which the new technology of digitalization has given us a huge advance, but I think it carries with it the danger of a reduction of human contacts, particularly in medicine. In medicine, Dr. Frank, many years ago, has written that there are three main sources, three main impacts of a medical encounter. One is the medication which you are giving or other treatment. The second part is a placebo. But the third is what he called the non-specific aspects of treatment. These non-specific aspects of treatment are, for example, the expression of the respect which a patient has, which a doctor has for the patient. The way that he listens to him, that he shows empathy, that he is present, etc. And these contribute at least 1/3 of all success that we have in treatment. Now, once you switch into telemedicine, this third part disappears because there is a magic about being with people which is very different from sitting in front of a television screen. And I think that is the great danger that we are seeing in it. It's wonderful that we have the benefit from it, but I think that we should be extremely careful to preserve time for human contact rather than allow ourselves to be seduced by the wonderful opportunities that technology offers us. Now there's a report from the United States, but also another one from Europe, that children of 11 to 12 spend 80% of their time on the computer or on the telephone. I'm sure they are learning wonderful things and they have good contact with everybody, but they have no human contact. They have not learned how to be with people. And I think that's something that is terrible. The problem of digitalization is, of course, that it's very seductive and everybody likes to play with it and it does many useful things. So my sense is we should use and try to use the benefits which it offers, but be very careful not to lose the human contact that we have to have if we want to live in a society which is acceptable. Otherwise, we'll end up. There's a wonderful book that was written by an author by the name of Asimov some years ago, and it was called The Caves of Steel. It describes a future in which people are afraid of meeting anybody because they do not know what to do with them. They are living alone on their own, connected perfectly well with everybody by telephones and Zooms and whatever, but they don't know how to shake a hand. They don't know what they are allowed to do and what not allowed to do. It's particularly true for children, I think, that one should be very careful in mixing putting together technology education, but also education in the classical sense of interhuman relations that are within us. So while I admit the great advantages of technology and digitalization, I'm very much aware of the dangers that it presents for the society as a whole and for medicine in particular.
Thank you very much. Before going to the next question asker, Let me repeat the request of Dr. Sartorius. Please open your cameras and let's see your faces. Who wants to ask another question?
I can ask the question.
Please, Dere.
So,
Please just say a few words about yourself, but only a few words, please.
okay. I'm a newly graduated medical student. My name is Darren, and I am into psychiatry. It is an option for me, but also a passion for choosing an option. That's all. Now I will ask the question. What would you say about motivation, hard work, and regrets after working so hard? According to your experience, what do you think about burnout?
Well, epidemic, they are speaking about burnout as an epidemic. And it's true, for example, among young psychiatrists in Europe, up to 50% of them have shown, in a survey that was done some time ago, 50% have shown signs of burnout. And it is a terrible danger. And it is explicable by several reasons, which I think were very important. One of them is what has happened in the 1930s in France. They discovered that many workers were having accidents. And then they explored what was wrong, etc. And then the sociologists have invented the term fragmentation of labor. And the fragmentation of labor was that the people who were working in the factory, they did one little piece, but they never saw the product of what they have been doing. They would put in a screw, but then they never saw the car which came out of it at the end. And the absence of reward of that sense has been a very significant factor, leading to great dissatisfaction and problems at work. And I think burnout, in a way, is becoming epidemic precisely because of the fragmentation of our society and fragmentation of everybody's work. Because you are no longer spending all of your time with a particular topic or with a particular patient. You are doing a little piece, and then medicine is fragmented into 1,000 things. So you send this patient to 10 other people who he disappears, the patient goes somewhere else. Even if you treat him, you finally never you never get the satisfaction of having supervised the treatment, been with the treatment, given this person your heart, and in the end see him or her getting better. It's gone because you have split the patient into 1,000 pieces as well, for somatic illness, for school tests, for psychological tests, for God knows what. So that in general, many people will now, while a shoemaker in previous times, he would take a piece of leather and he would create a shoe, and he would look at the shoe and say, look, I produced a shoe. Nowadays, this kind of I have produced something has been weakened very significantly. And what we are seeing our piece of work that we are doing, but we never see the total product that we have produced. And at the end of the day, we feel that we've done nothing, that we spend the whole day doing absolutely useless things, which lead nowhere. You have not, in the whole day, you have not got a moment of satisfaction, of recognition that you've produced something. And that is true for all disciplines, including medicine as well. It has been shown, for example, that a general practitioner, on average nowadays, spends between 20 and 25 seconds before he interrupts the patient speaking, because he doesn't have time, because he has to go somewhere else. So I think that the fragmentation of our work in general is a very important contributor to the burnout. Another contributor to burnout is, of course, also that the human relations outside of the work situation have weakened. One thing that happened is the so-called horizontalization of society, in which basically says that people are communicating and they are close to one another within the same layer. So that adolescents speak to other adolescents. They are in that layer, they use a language that they very well understand. They have words which they have invented, and they talk with them, but they do not understand the elderly, and the elderly don't understand them either. So that, in fact, the horizontalization, which means that you are only communicating within your own layer, either professional or other or age, uh, has reduced the number of human contacts. So that what you have is a combination of a smaller number of cordial contacts with a complete disappearance of reward for what you have done, which leads to a burnout. You can't continue like that. You do all day something, you never see the result of it. Patients whom you have started treating end up, God knows where, they go away to other specialists, to other things, to social workers, to, I don't know, psychologists, other. You never see them anymore. You have not treated that patient. You have not given him health again, which was previously the great reward of a doctor. The great reward was not the money which you got. Money was very nice as well, but it was the fact that you have a sick person in front of you. You do something, and he awakens and becomes again a person who can. And I think that that is particularly true for younger people who are not allowed to organize their own time. They are, in fact, being organized. They have to incorporate themselves into the system, which means that they will have meetings every so often, responses to this, that, and the other, seeing patients or not seeing patients. The continuity and the wholeness of work and of life has been broken up. And I think that leads to a great epidemic of burnout worldwide. And we have to do something. We should, as psychiatrists, we should know that. But we are maybe knowing it, but we are not really actively going, not even within our own profession, are we paying attention to these factors I have mentioned.
Do you have any advice on it?
Yes, I think in my sense is one should probably preserve one more, sacrifice some of the extra examinations, for example, and deal with the patient only. Let the patient speak sufficiently long to say what he wants to say, not interrupting him. It's less important to have a wonderful case description as it is for the person to have been able to speak to somebody for a while. And I think that as our treatment technique, our treatment improves itself, the reward coming from the patient and then getting better is a great contribution to continuing the work. Second, we should also, particularly at your age, you should ask yourself, am I in the right profession for my life? Am I willing to spend 40 more years doing exactly what I'm doing now? It's now the time that you ask yourself that, because years are going by and you will end up 40 years later saying, I spent my life for nothing. So if you don't like what you're doing now, I think it's a good thing to think it's not a must. There are many options that people have. And I think that one has to think, where am I going with myself? What is it that I'm going to be? Where is all this leading? What are my priorities in life? And I think rather than roll as you are pushed, stop and think for a moment. Somebody has advised that you should spend approximately 5 to 10 minutes every day to think about yourself, about what is my priority, what do I want to do with myself, what is the most important, etc. Just spending time with yourself for a moment to think, where am I going? And I think that it's a wonderful advice, very often very helpful, because it will allow you to gradually discover what is truly important for you and for the close people who are very close to you, and what is less important. And so you'll be able to reject things that intrude into your life and into your work schedule and make you live a life that is worth living.
Thanks a lot.
Thank you. Next, friend. Time for us, for ourselves, is very important. And so we have limited time here. Don't forget.
I will ask, but I am organizing the questions because I have asked last week, before this week. It is a long question. I'm organizing it. I will ask.
Now, you are not asking the question. You are just saying you are organizing.
Yes, I want to say it.
So as soon as possible, with a brief information about yourself when you are ready.
Okay.
I can talk while Bartu's
Please,
doing
Daphne.
her questions. Okay, first of all, hi, my name is Daphne. I'm a second year medical student, so I still consider myself as a beginner. And my question might be more simple, but I was wondering what book recommendations and advices would give to medical students and psychiatrists in their early careers. And thank you for sharing your time, precious time with us. We are so glad to be here, and I'm pretty excited right now.
Okay. Well, for a medical student, I think to an extent the same applies. We have medical students, there's been a wonderful study that has been done in Edinburgh, in Scotland, in which they examined what is the chief kind of interest and what do people think about from their first year of their medical studies to in the course of their studies. And they've discovered that when students enter into medical school, they think about society, about saving people from death, about being surrounded by grateful patients, and by having a respect in the community because people will think he is a doctor and he knows everything, etc. But as time goes by, they become less and less interested in all these things. And by the fourth or fifth year of their studies, they are to a large extent concerned with the day-to-day things. They have these ideals that were present for them and the expectations have all been collapsed somehow. And they just think how to get through the exams and how to finish all this and get rid of the faculty and get rid of the university and get finally to work somewhere. And I think that is everywhere. And to an extent, there are several reasons for it. The one is the overburden that you have. And because for reasons that are unknown, you are given an enormous amount of information, most of which is useless by all of the subjects they will never be used in your. I'm reminded of this in elementary and graduate school in gymnasium. That is, remember how much mathematics you have learned. And remember that today all you do is knowing how to subtract and how to add. That's about as much as one does. And all the complicated algebraic things and all these things have all been loaded upon you, and eventually they were of no particular usefulness. So I think that for a medical student, what is of great importance is to seek the very essence of medicine in what he is doing day to day. Maybe you are not quite sure at which year you are now, but I do not know whether you have contacts with patients yet or not, whether you're seeing patients. So once you start seeing patients, it will be you will probably have an opportunity to decide how much time you spend with them, what do you want to hear from them, how much of your heart you want to give to them. But meanwhile, remember that the first years, you should try to lead a good life with colleagues, with friends, with family, and put emphasis on that as the first priority. It's the second priority is to learn much of what you have to learn it by heart, because most of it is useless. I remember that I've been taught histology for a whole year. I don't know a single thing about anything that has been done there. Zero. I've never used it. But I had to pass an exam. So that's unfortunately true. So take the medical studies as being a necessary evil in the first year or two, and try to build a life around your age and your friends, etc., gradually developing also an idea of where is the main interest that you have in medicine. What will it be doing in general practice or in a high society or high science or whichever else? But I think that it's a very frequent thing that you are experiencing.
Thank you for your answer. It was really helpful. And I have one more question, if that's okay.
Sure.
Okay, as medical students, I was wondering what can we do to reduce the stigma on mental health disorders and increase the mental health literacy on medical students or young adults?
The first one is how to decrease the stigma of people who have mental illness. And the
Yeah.
second?
And to increase the mental health literacy.
Increase your own mental health. Or
Our medical students and young adults.
Okay. Now, the most powerful way to decrease stigma, and there is no other that is better, is social contact. It is when you meet people who had a mental problem that you discover that they are also human, and that you discover that you shouldn't be afraid of them, etc. And we have, in the past, we've done quite often. We would ask a person who had a mental illness to come and speak in elementary and graduate school to speak about himself and what was happening. And people are usually surprised because their image of a mentally ill people is a raving maniac who runs about with a knife. But 10% of people are mentally ill. 10% of all people in the world have a mental illness of some type. So it is, in fact, the small things which are invisible, so to say. And I think it's the important, probably, thing in fighting stigma is to try to facilitate social contact between different people who have mental illness and others, and gradually make people aware that it is not so terrible. Knowledge alone is not very helpful because of a phenomenon that is called selective memory and selective perception. If you are, if, for example, you are prejudiced, you have you think that mentally ill people are terrible, and then somebody comes to you and says, mentally ill people are in fact only 5 out of 100 people with mental illness commit a crime, while in the normal population, 10 out of 100 commit a crime. If you're prejudiced, your mind selects what is in harmony with your prejudice. So you remember that 5 people among the mentally ill have killed, but you forget that 10 people of the normal have been killing. That is evaded. So it's the selective memory and selective perception which contributes. And the fight against it is really trying to see direct contacts with people who have a mental illness, either, for example, to invite them to come to speak to students, so that you lose your fear of the people and that you recognize that many of the things that they tell you is the same as you feel occasionally when you are down. There are, of course, some extreme cases, but extreme cases of psychiatry are very rare. They are not all that frequent. The large majority of patients are mildly depressed, anxious, uncertain, people of this type who are miserable. And I think it's these kind of people who are the enormous bulk of people who have mental illness.
Thank you so much, Professor Sartorius.
I think the second part was related with mental health literacy, how to understand, how to read mental health. Is it so, Daphne?
Well, mental health literacy is dangerous because you have to deal with emotion before you deal with facts. I just gave you an example of the selective memory. If you just provide people with information about mental illness, they will remember the bad things about the mentally ill because they are selecting items that support their ideas. So one has to be very careful of operating with the emotions as well as with the facts. And health literacy is always facts. And facts are very often misused. They are used in constructing an image which is not very positive. So I think that to do health literacy, to my point, the best thing is to meet people who have a mental illness, who can tell you about what they experienced, much better than giving them a lecture about depression. Let the patient who comes along tell you what he or she feels. We have done a little bit of that in that we have asked students in particular, relatively early in their career, maybe in the first, second year, to meet some people with mild mental disorder, just to understand that these are not monsters who will kill them, but just people like you and I, who all of us have these feelings as well, but maybe not so permanent as others.
Okay, thank you very much. And Bartu wants to introduce himself and ask a question.
Hello, Professor Sartorius. It is known fact that the suicide rate of psychiatrists is higher than other colleges. There is information that the reason for this is psychiatric disorders. Some of them cannot receive treatment in order to avoid being labeled. There is information in the literature. There are informations in the literature. After the suicide of Dr. Emerson, that issue was discussed in England. She was a psychiatrist, was a bipolar disorder, and Taleb el-Abdul Mohsen, who committed for attack in Germany, and a child psychiatrist in our country was arrested due to his unethical approach, ketamine infusion. My question is, the training of psychiatrists, how possible it is in the terms of ethics and feasibility to manage and inspect their mental health during the post-operative period, post-graduate period.
I'm not quite sure that I understand this question. Can you just please give it once more? I think I've lost you somewhere.
How can we inspect psychiatrist mental health during the residency and after their residence, during their professional
How can
working?
we ensure that psychiatrists are not getting crazy? Is that
Yes,
what you're asking?
I gave some examples about this. They are rare, but it can be happen.
Yeah, well, if you're asking about psychiatric mental health of psychiatrists, one has to understand that the majority of psychiatrists are people who have just selected this discipline for a variety of reasons. But some of them have selected medicine, psychiatry, because of their own problems, thinking that maybe they will be able to better understand themselves and that they will be able to help themselves and live better in the future. It has been, for years, people have been trying to introduce the notion that not everybody can become just what you like to be, and particularly that in order to be allowed to enter into psychiatric training, that you should, before you do that, you should in fact be interviewed by people who are experienced and who will tell you whether they feel that being in a professional psychiatry will be good for you and good for other people. And this unfortunately has been not taken seriously. And so people are allowed to go to any discipline that they feel will be good for them. But while the discipline may be good for them, maybe they're not good for the discipline. And so one has to think about who do you allow in. And very often people are not sufficiently brave to say you cannot do psychiatry because it will be bad for you. You will suffer and your patients will suffer. So please select something else, become a radiologist or I don't know, become something else, become another discipline. And I think that's a responsibility that teachers have to tell people you should be careful about, don't go into discipline, go into some other discipline. In the same way as you should also be careful not entering any other discipline. But for psychiatry, I think it's so particularly important to be advised whether you should do this or should not do this. It is helpful to you and will be helpful for patients subsequently.
But sometimes teachers cannot be able to detect their problems. It may happen later, maybe after a big trauma.
Well, psychiatrists are surprisingly, or should be, just normal people. And I think that that's mean that they will be as likely to have mental illness as anybody else. The fact that they have a lot of knowledge doesn't prevent them from being falling sick either. So I think that the the important thing probably, which has been done in McMaster's University and some others, was to expose the medical students very early to all disciplines at the same time, so that they have had about 70% of their teaching was on problem teaching, where a patient would come and then they would be examined, interviewed, advised by several doctors of different professions, which allowed the students also to see which of these professions or which of these specialities is the one that they would like to do themselves. I think it was a very useful initiative. It has been done. It is, of course, the problem in today's world where money is so important. It's very expensive to do teaching like that, where you have 3 or 4 or 5 people who are specialists, sit down, a patient comes along, they talk about him, they talk about what was happening, etc., which means that 5 of them have had an hour of teaching, which is more expensive than having one teaching after the other. But I feel still that seeing a patient by several people at the same time and trying to discuss what would be the best way to go about it will show you what kind of things psychiatrists have to do and know, what kind of things other professions have to do, and will make your choice for a discipline or for the predominant work much more reasonable. It's been I've been very interested in the career of some people who decided relatively early that they don't like what they are doing. Which is, somebody does psychiatry or medicine for that matter, psychiatry, and after about 3 years, he doesn't feel very happy about it. Now, there are 2 ways of going there. One is you're not very happy about it, but you continue hoping it will get better. You go to specialities within psychiatry, and more or less life goes by, and the next 40 years you spend and you go to retirement. But you have a life that was basically characterized by being a miserable life, because all the time you have been, so to say, trying to adjust, etc. And there has been now in some health administrations, they have created what is called exit doors, which is you are a psychiatrist and you have been working for 2 years to learn how to become a psychiatrist, or for that matter, any radiologist or something else. And you discover that it's boring in the extreme and you really don't like to do it at all. And then they have created a career path which allows you to switch out of that particular discipline and take another one. Now, as years go by, I became convinced that if you don't like what you're doing, you should not persist too much. You should persist for a while. But if you discover that it really doesn't work, you should take the courage and change. It will cost you quite a bit of effort to survive in the other one, in the new one. But I think it's better than letting yourself roll for 40 years in a job that you don't like, in a profession that you don't like, with people whom you don't like, in a country that you don't like. So I think that one has to, at your age probably, take the courage of taking a pathway which is dangerous and a little bit more expensive perhaps, rather than just continuing or rolling away, waiting for retirement to come.
Before going to, thank you, Dr. Sartorius, thank you, Bartu. Before going to Frilia, I would like to underline one thing which you have said. you have counted several things, and including your country. In these days, we have lots of people, young people in our country who don't want to live further in this country. That may be another topic at another time to discuss with you, maybe. Yes, Frilia, could you please introduce yourself briefly and ask your question?
Thank you so much for the opportunity, Prof. Bowen. Good afternoon from Indonesia, Prof. Norman Sartorius. I'm Frilia from Indonesia. I'm a child adolescent psychiatrist. I have a question. Indonesian Psychiatric Association plans to hold like a national conference involving section on bipolar and mood disorders, women's mental health, and early career psychiatrists. There are collaboration between others. My question is, do you have any suggestion for the topics that correlate with women's mental health, bipolar disorders, and mood disorders, and also women's mental health or early career psychiatrists that can answer the need related to the current issues? Thank you.
I'm not quite sure. You're saying this is for young psychiatrists, whether they have... Go ahead.
Yeah.
Yeah.
The participant will be in general, this is not only early career psychiatrists, but also senior psychiatrists. Yeah, the challenge how we can provide for the two populations. It's not only early career psychiatrists, but also for the senior psychiatrists.
Yeah, I'm very sorry, but I seem not to be quite sure to have understood, and I don't want to speak nonsense in answer. Can you just tell me once more what specifically is the question?
Do you have any topic related to answer the need related to the current issues about the Congress, the National Congress? Like what I said before, an Indonesian Psychiatric Association plans to hold like a national conference. It will involve 3 sections on this conference. Sections on women's mental health, bipolar and mood disorders, and early career psychiatrists.
I'm a little bit at a loss.
Yeah, I can understand. Probably still be confusing.
You're saying in a conference or
yes.
a conference, yes?
But the topic.
Topic for a conference.
Yes, topic the conference.
You would like me to give you a suggestion for a topic?
Yes. Probably do you have any idea?
Okay. Well, my topics now are, I have more recently been more and more convinced that the great priority for psychiatry today is how to maintain and support carers of people with mental illness, people who look after other people. They have people, for example, the wife of a person with schizophrenia, or a son or a daughter of a person who has dementia. How can we support them? We have practically, we know that they are giving their life to keep this other person alive and well. So how can we help them? They have higher physical morbidity. They have higher mental morbidity. They live a life that is empty because nobody is helping them. So how can we help them? And I've been thinking about various ways, but I think that it's a topic that is somehow not mentioned. For example, when you are sitting in a department of psychiatry and you discharge a patient, there is no obligation to find out whether there is something on the other side to which he goes, which will receive him, which will help him, which will be with him. We are very poorly paying any respect to what the carers have to tell us. We are not listening to them. Instead of inviting them to come to teach medical students about the ways of living with a person with a mental illness, we are teaching them, although we are not necessarily very personally experienced with this. So I think one great priority and a topic for a conference to me was how do we help people who care for people with mental illness? How do we help children, parents, families? What do we do for the parents of a child which is autistic? What can we do for them, not for the child? They will do whatever is necessary for the child, but what do we do for them? In what way can we make their life better? There has been a wonderful study done by a lady by the name of DuPont some years ago in Denmark. She has been examining what is the content of the life of women who have a mentally retarded child. And she asked them questions. Are you reading newspapers? No. Are you going out for walks? No. Are you going shopping? No. Are you having sexual intercourse with your husband? No. There was nothing in their life except for the care for this particular child. So she decided that she has to change this, but she didn't have money to do it. So what she did is she brought together 6 of these mothers, and she said, how about 2 of you looking after 6 children for one day? Would you do that? And she said, oh, okay. And so they arranged a system by which the mothers were looking after children of all of the little group for one day or 2 days a week, but the rest of the days they had a few hours of time to themselves, to think, to sleep, to go shopping, to go to the hairdresser, to look after themselves. And it changed the life of everybody. But the main point about this paper was that the life of a carer is extremely reduced, and nobody of us doctors pays much attention to their life. The consequences are visible. We see now that, for example, in Bangladesh, there is now legislation which will punish very severely people who do not look after their parents. And I think that is a reflection of the fact that people stop doing it because they want to live a life as well. And I think that we have to think within our own discipline and our practice, what can we do to help carers? So that is my great priority, and I'd like to see a conference about how to help carers. Other topics that are of importance, I think, is the education of the doctors, how to prepare them, not giving them more knowledge, but giving them skills which they will use in their work. They have to learn how to listen. They have to learn how to speak convincingly. Many of these things. And I think that that's the second topic, which is really a revision of the medical school from the current system in which you get a lot of information to a system in which you get information, but the emphasis is placed on getting skills, ways of doing things, which will help you in your work. So these are my 2 topics I would suggest for a meeting. In addition, of course, to the classical one, which everybody studies all the time.
Many thanks. Yeah.
Thank
Now,
you so
Ahmed,
much.
we are running time. We have running time. After Ahmed, we may have one more question, maybe. Please, Ahmed, introduce yourself briefly and ask your question.
Hello, I'm Ahmet, first year medical student, so I know little about medical topics, but my mind still doesn't get how people join cults. So my question is that how is it possible to diminish someone's ability to question so much that they join a cult?
I'm sorry, something is wrong with it. Once more the question.
How is it possible to diminish someone's ability to question so much that they join a cult?
How much Please repeat it once more. I do apologize.
All right. How is it possible to diminish someone's ability to question so much that they join a cult?
That they join a court.
Yes.
I'm not sure. I'll repeat the question. Tell me whether I understood it well. How much is it possible to diminish one's possibility to so much that they join the court? Sorry.
Maybe headset makes the problem. How is it possible to diminish someone's ability to question that they join a cult?
You mean a cult?
Yes, cult.
Somebody, you would like to know how to diminish the ability to question?
Yes. How they do it? Like, how is it possible?
Well, but the way in which you can diminish everybody is just not to listen to him or her. As long as once you stop reacting to what people are doing, they eventually stop doing it. It is most of our action in life, in general, all humans, is they emit an event, they emit a word, and they expect a reflection. If they don't get an echo, if they don't get a reply, they unlearn how to ask and they stop asking. So the question is, to what an extent can we increase the people responding rather than how to, because the main way to contribute to people asking questions, etc., is by listening to them and by responding to them. But if you are silent, if you don't react at all, people will stop asking questions. They're not interested. They can't do it. It's like shouting into a wind. There's nothing coming to it. The main way of reducing and destroying human communication is to stop listening. If people stop listening, society falls apart.
Yeah, but I'm asking, why don't they question what they're doing? Why don't they question themselves, their acts? Because they're acting towards basically a cult. They're basically doing what they're told. Why don't they question?
Well, one of the great problems of now our age, and I think, is that the style of life that we have everywhere is reducing the time that parents spend with their children. Now, the children in the early age, between 6 to 9 months, even before that, they are very much dependent on the amount of interaction which you establish with them. But as years go by, the first 2, 3, 4, 5, 6 years of life, in those years, practically all of the concepts which make our life are created. A child of 3 is capable to create concept, and it's doing it all the time. For example, there are animals which are big and small and brown and white and black and green, and they are dangerous and other. But the thing that is common for them is the children discovered that it's the bark. Anything that barks is a dog. So it has created the dog concept. And I'm giving you this as an example because the children create about 70% of all the concepts in life during the first 5 years of their life. So that their structure is created in the first 1,500 days of life. And it's during those days that we are not giving them sufficient attention. Parents very often start working very soon. It is rarely possible to have a part-time job for the mother and the father to look after the child and to answer questions and stimulate it and create concepts with them. Very, very little. So that in fact, this child grows in many ways incomplete because it has not been given support in creating concepts which will make it understand the world. And it's about probably the biggest problem of our society is that we have children, but we don't have time for children. And I think that what one can do about it is unknown. But it's certainly one of the things that one would like to do is if you decide to have children, you have to find out, you and your husband or wife have to find time to work part-time and spend time making these children capable to enter into the world. And many of those who do not know how to ask questions or who are not reacting to questions, etc., have grown up without really learning the elementary social skills, which you learn in the very first years of your life. And I think that the current style of life reduces the capacity to do that. You have now in Saudi Arabia many children who don't speak Arabic because their parents never spend any time with them. It's the Filipino nurses who have been looking after them, and they speak Tagalog. And the parents complain that children don't want to listen to them because they've never had that contact with them, because they didn't invest themselves into it. So I think probably the answer to your question is in the early formative years of growing, when we are where we are failing to do what needs to be done.
So if someone has a great childhood, great 500 years or 500 days, they cannot join a cult, basically, is what you're saying. They have ability to question, we cannot get their ability to question diminished that much that they join a cult.
Well, it's a big problem of our society, and one has to really think what are the ways in which one can solution this. The solutions exist, but they depend on the society, on the culture, on the background of the people, on their profession, on many other things. But the step one is to become aware of the danger that resides in this style of organizing life.
Thank you.
Thank you. Thank you, Dr. Sartorius. It's already 1 hour. Our 1 hour is completed, unfortunately. Thank you very much for your enlightening messages, especially the one, we have children, but we don't have time for children. That's a very important extract of these last words, I think. It would be very important to have more time with you. Maybe we could ask to be together with you some other time, if you would be available. But we have to finish now. Özge, you want to say something? A very brief last words from you, please.
Thank you very much. I heard, I think maybe Defne asked, would you have any book recommendations? Did I hear correctly? Any book recommendations for us? When you have time, would you mind sending book recommendations for psychiatrists in this age of world?
Now, I'll answer two things with this. Number one, we are just bringing out a book ourselves, Dr. Thornycroft and I, a book on skills for psychiatrists, in which how to teach about them, how to acquire them, how to have them. So this little booklet will be out, I think, within the next few months. I shouldn't be making publicity for it, but I think it will answer part of your question, because it will speak about skills, how to acquire them, and how to teach other people skills that you need in your daily life and in your profession. And I think you are very right in thinking I will have to probably give some time to producing a reading list of what is useful for people at different ages to read. It's amazing that the books which are most useful are useful for children as well as for the very old and for everybody in the middle. So that is reducing the total number of these books, I hope. Yes. Okay, but I'll be in touch with you. Okay.
Thanks a lot.
Thank you very much. Thank you for listening. Thank you for the questions. I'm sorry about sometimes the connection wasn't ideal, so I forced you to speak more, but I hope that the answers were okay. So
Of
thank you very
course.
much for listening. And I hope I'll see all the faces of all these people some other time. Thank you very much. Thank
Some
you.
other time, I hope so.
Sorry for interrupting, but if you have 5 more minutes, I believe, an important question for all of us.
Deren, let's leave it for the second
Okay.
session. Then we will have an important point. If you don't mind, let's hear your question, but not the answer. The answer, let's keep it for the next session.
Okay. I'm asking. I want to ask about being stigmatized because of your mental illness or learning disability. For example, if you have depression, ADHD, dyslexia, or something else, people might call you lazy, incompetent. There's the dilemma. Which one would harm you more as a doctor? Being called out such things or being outed, being stigmatized? Should we inform our seniors, the chief about our condition? What kind of talk should we have with them?
It's a wonderful question worthy of a full session. But meanwhile, please look at the Lancet Commission on Stigma report. There is a commission report which is you can download it. It's free of charge, and it gives a description of everything that we know today about stigma. It's published last year, so it should be easy to get it. It's the Lancet Commission on Stigma, and I think it should be no difficulty in getting it. So meanwhile, start with this. We'll talk more about it when we meet again.
Okay, thank you.
Very much.
Many thanks. Many thanks.
Thank you very much. Thank you all. Thank you.
Thanks. Thanks a lot.
Before we go, can we have a photo together? Oh my God, everyone's going.
Yeah, we have several people not offering their faces to be seen. Let's forget about the photo.